Yes, thank you, Mittal. I just received your message. So we're just going to start in the next 2-3 minutes. Let's wait for other to join us. Thank you so much for being on time. Thank you, Asma, Mittal, Salma. Hello, Moise. How are you? Hi, Falak. Nice to see you here. Shall we start the session? Hello. Hello, Falak, Bismil, Asma.
Yes, ma'am.
Yes, thank you so much, everyone, for being on time. And let's start the session. Today is our session 1, and it's an introductory session for part 3 MRCOG. And as this is my first session with all of you, so I'm going to start with my short introduction. My name is Dr. Alina Shirazi, and I'm one of the mentor med exam expert. Currently, I'm working as a senior clinical fellow in Queen's Hospital, Romford, London. And the name of my trust is Barking, Havering and Redbridge NHS Foundation Trust. In terms of my qualification, I'm MRCOG from UK, MRCOG, MRCPI from Ireland. I'm European Fellow of Obstetrics and Gynecology, Belgium, FCPS from Pakistan. And I just have recently completed my medical education from European Association of Medical Education, Dundee. So in terms of today's session, I believe it's a very important session because I'm going to cover bit by bit each and every module. And I'm not going to go into the depth because definitely we're going to cover these module in depth in our module wise session. It's just an introductory session. I'm going to give like a little bit touch the things and make you people prepare my level best before your module wise session. And if you have any questions, you can ask there and then. Even you can drop the message in the chat box and our team will be happy to assist you. Okay, so let's start. Okay, so what we are going to talk about today. So we're going to talk about part 3 curriculum, and I believe most of you already know about what's the module and what's included in the module. What is part 3 curriculum? It's been mentioned very detailed in RCOG e-learning. Okay, so certain tips how to prepare for part 3, all 14 modules, 5 domains, why domains are important, why we have to look into the domains before starting our task, what type of the tasks are expected to come in the exam, what are the tricky tasks, what are the tasks with the hidden agendas. I'm going to show you some of our templates and how we are going to help our student in our course. Okay, and how these templates are so much organized and they will help you to prepare for your exam. Course instructions, and it's about our ongoing course. It's just been started and today is our first introductory session of that course. And structure of NHS, how the system and how hospital and GP surgeries, everything work in NHS, and what to expect, what not to expect. At the same moment, I will discuss about MTD, I will discuss about incident reporting and risk management and maternity dashboard. And at the end, we are going to cover one task, that is a gynae board, because some of my students requested me to cover gynae board because they always find it very difficult. So these are basically agenda for today that we are going to cover. And if you have any questions, I will be happy to answer. Okay. Okay, so the 14 knowledge-based modules of RCOG: teaching, core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, postpartum problem, gynecological problems, subfertility, sexual reproductive health, early pregnancy care, oncology, and urogynecology. So these are the 14 modules basically, and you all know because you all have passed your part 2 exam. And I believe you all should proud of yourself that you have passed the most difficult exam. And part 2 MRCOG is much difficult as compared to the part 3 MRCOG, because part 3 is all about understanding the system, all about to understand how the things in NHS work. Okay, so part 3 is much easier as compared to the part 2. It's all about communication, it's all about patient safety, it's all about one question that should be in your mind every time: that am I a safe doctor? Am I doing the best thing for my patient? So this is all about this thing. Okay, it's not a difficult exam at all. Please forget about it. All IMGs, the international medical graduate, they think this exam is hell difficult. It's not like that. Okay, I passed this exam when I was in Pakistan, and then I got job after MRCOG in London, and then I come here. Okay, it's not like that. Anyone who is there in Pakistan, India, Middle East, anyone, they are not being able to pass the exam because they don't know about the system. It's not like that. Once you understand system, this exam would be very easy for you. Okay. Okay, so these are the 14 knowledge-based area of RCOG, and these are the 5 domains. So what are the 5 domains and why they are important? So who is going to tell me? Who wants to answer me about the domains? Why domains are important? Do you know, Falak? Falak, do you know why the domains are important?
Yes, ma'am. Ma'am, domains are important because we need to fulfill certain important things about each the domain, like some few things for the patient safety, few things that are important for being a good communicator with the patient, having a good communication with colleagues. So the domains are very important. We will be told about what domains are we being tested in the beginning, and we do not fulfill those things, we are going to lose the marks then.
Yes, exactly. So before, thank you so much, Falak, and
Yes,
absolutely it's the right answer. Just a couple of things I want to add. Before you see the task, before you have to think about domains. Okay, it's very important. For example, in one domain, there is no information gathering. Okay, and there is patient safety, communication with the patient, and there is applied knowledge. But there is no information gathering. Okay, no information gathering means history is not required. If you enter into the cubicle or even in your virtual exam, if this domain will be missing, that means you don't have to take history. Okay, if you waste your time in history, then you are not going to discover the hidden agenda, and you are not going to apply your knowledge, and you will miss certain very important aspect of other domains like patient safety, and it's not possible to pass this task. Okay, and for example, in one task, there is no applied knowledge, there is no information gathering, and there's just communication with the patient, communication with colleague, and the patient safety. Sometimes you can expect these 3 domains whenever there is a agenda like breaking bad news or sometimes domestic violence. In that task, RCOG only testing your communication skills, how you break a bad news to the patient. So you just have to focus on your communication. You have to offer tissue, you have to offer water, you have to offer sport, you have to offer the counselor, the sporting midwife, and you have to talk about the GP, and you have to talk about sport groups and these things. Okay. And for example, in the domestic violence, you have to talk about the domestic violence services. I'm here to help you. I will support you. And I'm going to respect your confidentiality. I'm not going to mention to your notes. I'm going to give you the 24-hour helpline number. And don't take it on your heart. I believe it's a difficult situation. It's all about communication. So you have to think about these things. If you waste your time in with information gathering, even if it's not required, and it's just about the communication, then you're going to lose your marks. If it's communication, it means it's just communication. Okay, for example, in my exam, there was a task of request for postmortem examination. So in that task, there was just mentioned about the patient safety. They just mentioned about the communication. So the task was just to show empathy. I'm going to support you. I know this is a very difficult time for you. And do you need some more help? Do you need some more support? And give them, like, offer them some water. And if she's crying, and then just stop there. And then if you say I can stop, and we will discuss it again later on. But I just want to tell you how this postmortem examination will be important. If we are going to delay the examination, then there's a less information we are going to get, and then that we will miss that information that we actually want, and it's going to affect your future pregnancy, darling. Okay, so it's very important to think about domain. This is my first step for all of you. If you forget, and if you will not focus on any of the domains and start doing like history, examination, investigation, management, blah, 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 you're not going to pass the task. Okay, so think about the domains only. If it's the communication, just focus on communication. If it's information gathering, just focus on information gathering. If it's applied knowledge, sometimes it's just applied knowledge. In my exam, there was a task of atypical hyperplasia, and they just mentioned about patient safety and applied knowledge. So history was not required. So I just see the task, and I asked from the patient, do you have anything to discuss with me before we start discussing about your report? Okay, and then it was all about applied knowledge, and many questions, many questions, how you're going to manage, and how the follow-up will be, and where I'm supposed to be referred, and many things. Okay, so this is the biggest mistake that IMGs do, the international medical graduates do, is they don't focus on the domains. So they forget many things. They try to manage, like ask history from all of the patient, examination on all of the patients. Not required. Okay, think about the domain before performing any task, and that's what we are going to practice in our course. Okay, so we will give you the certain tasks to perform in our live session, and in some of the tasks there will be 2 domains, there will be 3 domains, and every time we ask the student to focus on the domain and perform the task according to the domain. Okay, so this is the first tip for today's session. Okay, so 14 tasks, the most important thing I just want to tell you that there's no preparatory station, no rest station. Each station, each task has 12 minutes, 2-minute preparatory time, and 10 minutes for the performance. Okay, so assessor will present on every task. So I just checked recently your RCOG website, and they haven't mentioned about either this exam is going to be virtual exam and it's going to be either going to be face-to-face exam, because they're soon going to end up all restrictions from March. So there are chances that my exam will be a face-to-face exam. Okay, so you will expect an assessor to be present in every, like at least 1 assessor or 2 assessors will be present in every station, and you don't have to look on the examiner. Okay, so they will feel like it will be an embarrassing situation if you're looking on the examiner, then the role player, then examiner, then the role player. So it shouldn't be like that. So 2 types of tasks, basically simulated patient task or simulated colleague task, and there would be 4 lay examiners and structured discussion. Okay, so anyone of you know what is a lay examiner? Anyone wants to answer? Any volunteer? Asia, do you know what is lay examiner? Asia is my student, one of my favorite student. Hello. Okay, so Asma, yeah, Asia.
Hello.
Asia, do you know what is? Yeah, thank
hello,
you,
Dr. Alina.
Thank you. Very happy to see you here. Okay, Asia, can you please tell our students what is a lay examiner?
Actually, he or she can be anyone from public, or he's not a doctor. So anyone they will take. So she will judge, like mainly for communication, how we will talk with the patient, how we will explain the diagnosis, and either we use jargon or no.
Exactly.
So,
and the examiner, the assessor will ask only one question from the lay examiner. Is this the candidate you think, if you go, if you are the patient and you go towards the doctor, and are you going to be this candidate to be your permanent doctor? Okay. Do you think it's a safe doctor? Are you happy with the communication? That's it. If they say, yeah, we are happy with the communication, then the candidate will get 2 marks. Okay. Okay, thank you so much, Asia. Thank you so much for your participation. Now the time frame for each task. So 2 minutes outside the cubicle. So what you're going to do in 2 minutes. So you will have a paper and pen they will give you before you enter into the hall, examination hall. So in first 2 minutes, you have to write the name of the patient, age of the patient, agenda, because sometimes they mention agenda there, and domains, what domains you are going to cover, because you are going to take this paper inside the cubicle. Okay, so these things you're supposed to mention on that paper because you don't have much time. So write name, age, agenda, and domains. So 10 minutes. So first minute is very crucial. You need to show your confidence, smile on your face if it's required. But if it's a breaking bad news, then definitely smile is not required. Appropriate emotions is very important. If you think that there is an angry relative standing there or sitting there, then you have to maintain a very safe like distance, and your emotions should show that it's like your position should be a defensive position. Okay. Next 2 minutes, agenda. You have to explain agenda. Start open-ended questions. I'm going to discuss these in my next slides. Rapport building, which is very important. Okay. So next 3 minutes is for information gathering if it's required, and 7 minutes, then you can begin the task. That's it. Okay. So bell and timer, and you have a paper and a pencil with you, and then you can go to the next task, and then again write name, age, agenda, and domains. Okay. And prepare yourself before entering to the cubicle. Okay, think either it's a patient, it's a colleague, either it's a relative, it's a structured discussion, whatsoever is, prepare yourself and then enter into the cubicle. Okay. Okay, so one thing more, a second tip of the day, if you enter into the cubicle and you think that you have not read the task properly and you are not much sure about the task, you can even take 1 more minute and read the task. The same task will be there in the cubicle on the table. Okay, so you can read the task again, prepare yourself in that 1 minute, and then start your task. Okay, so always prepare yourself before starting task, and don't try to do the task blindly if you don't know anything. Understand the task, think about the domains, and then start. Okay, and then you can win the situation. Okay, so domain 1, which is I believe very important, and maybe you will expect this domain in all of the 14 module, which is a patient safety. And I think that without passing patient safety, without passing this domain, it's very hard to pass the exam, because this is most important, and one of the highest reason for litigation in NHS is if someone affect patient safety. Okay, so what is a patient safety? Appropriate and safe introduction. So there are 2 thoughts of introduction. Number one is, if you just see the notes and just say, can I confirm your hello, my name is Dr. Alina. I'm one of the senior doctor here in the clinic today. If it's you have to ask about whatsoever the setting is. Okay, it will be mentioned in your task. If in the task is mentioned as a gynae setting, you have to say, I'm one of the senior doctor in the gynae clinic today. If it's a pre-op clinic, then you have to say, I'm one of the senior doctor in the pre-operative clinic today. I'm one of the doctor in the sub-fertility clinic today. I'm one of the doctor in the labor ward today. Whatsoever the setting is, you have to introduce yourself according to the setting. Okay. And then you can say, okay, can you please confirm your name and age, please? And then she will say, okay, my name is Sonia Johns and I'm 28 years old. And either some of the patients say, like, mention about the date of birth. It all depends upon the role play. Okay, so how we do in NHS? In NHS, most of the time we see the name of the patient, and then how we introduce ourselves here. So, hi, I'm hello, Michelle Johns. Then she will say, yes, hi, I'm Alina, one of the doctor here in the clinic today. Nice to meet you. Okay, so it depends upon either you want to go for like ask from the patient name and age, and either you want to just pronounce the name of the patient and then confirm identity. Okay, so you can, like, it depends upon how comfortable you feel, which any of the approach, both are fine. Okay, so proper and safe introduction comes under patient safety is very important. Okay. Allergy is very, very important. You have to rule out allergy. You can ask, are you allergic to anything? It's an open-ended question, and then she will say, yes, doctor, I'm allergic to penicillin, or I'm allergic to food, some peanuts, or I'm allergic to fish, or I'm allergic to egg. Whatsoever the allergies, you have to, okay, thank you so much for letting me know, Sonia. I'm going to mention into your notes that you're allergic to that thing. Okay. One thing I just want you to don't forget about latex allergy. Is very important, especially in the preoperative clinic. Is very important in labor ward. Is very, very important, especially when you are just thinking to examine a patient. For example, any local examination, bimanual examination, anything. So it's so much important. In allergies, the most important is the medication allergy or the latex allergy, which you have to ask particularly for these allergies. Okay. Safeguarding concern, very important. If you have not ruled out the safeguarding concern, then your job will be at the risk here. So without fulfilling this criteria, it's very hard to pass the exam. So what is a safeguarding concern? You have to, when you ask from the patient and how you feel at home, do you feel well supported at home, whom you live with? Are you happy with your partner? And how's the situation at home? You can ask these questions in multiple manners. Okay, so safeguarding concern, very important in the maternal medicine. Optimize health before pregnancy also come under patient safety. So many things, basically different modules have a different aspect of the patient safety. I will show you in my next slides, okay, to have an idea about what are the patient safety aspects. Okay, what else will be Jehovah Witness? Whenever you ask, are you okay with the blood transfusion in case of need? Are you okay with the blood or blood products in case of need? You can ask this question like that. Respect confidentiality. If you think that like the patient is a case of depression, if it's a case of if it's a case of a patient don't want to discuss this thing with anyone, and sometimes with the sexual health clinic, then you have to say that, Sonia, I just want to let you know what we will discuss today will be strictly confidential, and I'm not going to share this information to anyone without your consent. Will that be okay, Sarah? Shall we continue? Okay, it's like that. So examination, the consent is very important, very important. Before performing abdominal examination, very important. Are you okay for me to examine? Thank you so much. My hands, you will feel my hands a little bit cold, and I'm so sorry for that. Let me know if you hurt anywhere. I will stop at the same time. This is patient safety. Okay. And before performing local examination, you have to ask about the same thing. Okay. I'm going to do the vaginal. I'm going to do the vaginal examination. Okay, and if you feel any pain, just let me know, then we will stop there and then. Okay, so and the teaching, bullying, very important. In the teaching task, you have to ask how you feel. So, hi Lisa, I'm Alina, I'm one of SD5, and how you feeling? Are you coping well here? Do you feel support? Do you need any help here? So it's very important. You have to ask from your junior every time that how they're getting on. Okay, because bullying, if you ignore this thing, that it also comes under the safety. It's not patient safety, but it's against safety. Okay, so safety of the colleague is as important as a patient safety. Okay, so patient safety management. Okay, so one thing, always confirm name of the patient, date of birth, and NHS number on the report. This is very important. You have to ask it, can you please confirm your name and date of birth again for me, please? Or you can say, okay, I have confirmed your name, your date of birth, and NHS number on the report, and I just want to tell you that this report belongs to you. Okay. So refer to senior, very important. You should have an idea about your limitations. Okay. If any of the candidate who is excellent in everything, and he know that how to manage this urological condition, and I will do this, I will do that, and how I will do this surgery like that. This will be the procedure. This will be the complication, and this will be the benefits and everything. And if we miss about his limitation as ST5, you should know your limitation. Okay. Few things that you would expect to manage at ST5, and few things that you should refer to your consultant, you should refer to your senior. It's not like you have to refer everything. For example, you have a patient present with shortness of breath, palpitation, okay? And it's not like after seeing the patient with shortness of breath and palpitation, you're going to call your consultant, and I'm going to inform the consultant that you are having shortness of breath, you are having palpitation. No, you have to investigate this further. You have to do ECG, repeat her bloods to find out either she is anemic or not. You have to arrange chest X-ray for her. You have to arrange VQ scan for her depending upon the chest X-ray finding. If VQ scan show it's a pulmonary embolism, or if the Doppler of the leg show it's a DVT, at that point it's your job to inform consultant, is your job to inform hematologist. If you will not do, even if you manage the patient with the treatment dose of Clexane and you have explained the risk and benefit, you ask the patient to be in follow-up, you have explained the red flag signs, still you will not pass this task. So it also comes under patient safety. You should know your limitation. Where is the point that I have to refer this patient, or I have to inform my consultant here? So this is very important. Call for help, obstetric emergency, patient safety, WHO checklist, patient safety. I will tell you inshallah in my next session, and every procedure has a separate WHO checklist. Okay, so we will discuss particularly in the core surgical skills module. SBAR tool, situation, background assessment recommendation is a safest patient handover perform. I will show you in the next slides. It's very important. It also comes under the patient safety because the effective manner of the handover prevent many complications. So clinical governance issue, debriefing with the duty of candor, documentation comes under patient safety, incident reporting is a patient safety, reflective practice is also a patient safety. Okay, so this is all about patient safety, the few things more. Okay, so I believe MTD is also a patient safety. Okay, if you can tell us some, yes, Falak, in my next slide, I will tell you about how to do that SPR. Okay, don't worry about it. Okay, so MTD is a multidisciplinary team. This is very important, very important, because at some point you have to decide this is the limitation after which the consultant and we are not going to manage this patient, and this patient should be under a team. Okay, so there are few MTDs that actually work here in UK. Number one MTD is endometriosis MTD. Not every endometriotic patient you have to refer to MTD. It's just if you have a patient who has a multiple surgeries for endometriosis and she presents with pain, then you have to refer this patient to endometriosis MTD. Not every patient, please. Okay. Okay, so if you have a patient with multiple previous surgeries, okay, and now you have to plan further. So for example, if you have a patient with if you have a patient with ovarian cyst, or if you have a patient with fibroid and she has a surgery of that fibroid, or even the surgery of the ovarian cyst, and she has a recurrent cyst. Okay, so the thing is happening with her again and again, and you are suspecting there will be much adhesions inside, and that case will be much complicated. Then you have to refer this patient to complex surgical MTD. So the team of the doctors, which will include the surgeons, which will include the urologists, which will include the gynecologists, they always sit together and make a plan for her. Okay. For example, you have a patient with a multiple fibroid, her hemoglobin is 6. So maybe they will plan to put her on Zoladex injection, that is GnRH agonist, and then shrink the size of the uterus and perform the procedure laparoscopically. Okay. They will decide about the port entry, either to enter into either enter from the umbilical port or either enter from the palmar port. Maybe they will ask to investigate further in the form of MRI. Okay, so the complex surgical MTD will decide further about this case. Okay. Another MTD is a chronic pelvic pain MTD. If you have a patient, you are not being able to find any cause. Okay, and laparoscopy is already been done and it has ruled out endometriosis, and then that patient needs to be referred to MTD. And what is included in that MTD? Pain team, radiologist, and gynecologist, and pain nurse. Okay. Okay, so another MTD is urogyne MTD, and not every urogyne patient you have to refer for this MTD, only the patient who had previous surgery for any of the urogyne procedure. For example, recurrent wall prolapse, for example, patient who had the surgery for stress incontinence or overactive bladder or retrusor overactivity, whatsoever is. But in case of before second surgery, you have to refer this patient to urogyne MTD. Another MTD is an oncology MTD. Oncology MTD, any patient that you are suspecting cancer, you have to refer to oncology MTD. For example, if a patient with postmenopausal bleeding and endometrial thickness is 6 mm, 7 mm, and you have to refer this patient to oncology MTD. For example, a postmenopausal lady with a huge complex ovarian masses with solid components with raised CA125, refer to oncology MTD. For example, a patient with cervical invasive carcinoma, refer to oncology MTD. For example, the patient with vulvar lesions and you are suspecting vulvar carcinoma, refer to oncology MTD. So these are basically 5 MTD that actually works in NHS. You should have an idea about when and where you can refer these MTDs. Okay, so ward clerk is basically the person. I'm telling this because this might be helpful for you in gynae board. So you can say, I'm going to inform ward clerk that we need a referral, we need an arrangement of referral to be done for this patient to endometriosis MTD or complex surgical MTD, chronic pelvic MTD, urogyne MTD, or oncology MTD. Okay, that's fine. Okay, so moving forward. Okay, so now the second domain is a communication. Okay, so this is a rule of thumb that the 50% of the communication is a body language. Okay, and your confidence, your eye-to-eye contact, your dressing, your way of talking, okay, your expressions, your arms and face, the way you're handling yourself, it comes under 55%. 30% is your tone of voice, modulation, the pauses, the break you take in between, and the 7% is a word. Okay, so communication is very important because in the communication there will be merging of some part of information gathering, some part of applied knowledge, or some part of patient safety. So what comes under the communication? In the communication, when you talk with the patient, and the first important thing is your the most important thing is your first encounter with the patient, your first impression. And always there is a rule that the first impression is the last impression. If you can see the dressing, you should dress like that. You should look very, you should look modern. But on the other hand, just wear the dress that look much formal. And your attire should be like just because in UK we don't wear the lab coat here. It's in America, it's in Pakistan, it's in India, but it's not in UK. Okay, so you should dress like that. That's why I have attached a picture here. Okay, there should be smile on your face. You can open your hair if it's a short hair, and you can tie your hair. It depends upon you, whatsoever is suitable for you. But to be honest, you should look nice, you should look beautiful. Okay, this is very important. You should look smart, and obviously you should look very confident. Okay, so this
Dr.
is a picture
Alina,
of, yes?
hello, Dr. Zev here. How are
Yeah,
you?
Dr.
Thank you so
Dev,
much.
hi.
Hello. Yeah, first of all, thank you so much. I've been listening to you, and till you have reached to this slide that your body posture is going to be like, I mean, it should be like kind of relaxed. And you won't believe, what I noticed these days is that everybody looks so robotic. They have so robotic
Exactly.
impressions on their expressions on their face, and
Expression,
sometimes
yeah.
there is, yeah, how they are asking, okay, can I ask, do you drink? Do you smoke?
Do you smoke? Exactly.
Do you any recreational drugs? Oh, come on. I mean, it shouldn't be so robotic. And I 100% agree with you. I literally like that pie chart in which you have shown that 55% is your physical action. That how do you show from your expressions and hands and, the hands. That is, this, every candidate needs to be learned. Because seriously, I literally feel, lack in this thing that everybody, looks so robotic. It's like that,
Exactly.
if they will say something, so they are going to be scolded by somebody. So I think they need to learn how to relax, because communication is, you rightly mentioned that communication is a two-way, the kind of a process. If patient is like, or the role player is expressing something, so they have to express back as well. So it's not like that, they will be just like mask face, and then they will be just like, sitting, no expressions, no softening of their face, their face expressions, plus softening of the body posture as well. So I think, this everybody should learn, that the candidates who are aiming for May exam, so please try to focus on this as well, along with, every other thing, right? Like Dr. Alina is, very well explaining about everything. So this I really wanted to add in.
Thank you so much. Yes, Dr. Dev,
Thank
you're
you.
absolutely right. This is the same thing I have noticed.
Yes.
Yes, yeah. So that eye-to-eye contact and a safe, distance. And yes,
Exactly.
definitely you have to, like your expression should be reflect. Just like the similar expression you can see on the face of the role player. It's not like your role player is crying and you show the expression, or the happy expression on your face. It's not like that. So if your role player is sad, you should have an empathetic expression on your face. And on the same time, yes, the robotic expression is not good for the exam. Okay,
Yes.
and yeah, it's actually not good really well, even in the real life scenario. So
And I really would like to have your input on something that, while, we are taking sessions these days. So of course, everybody is like signposting for every question. So I would really like to have your few words and on this thing that, I mean, some personal question. So these are, now listen to me, how candidates say, and I'm so sorry if somebody is listening and, the he or she practices the same. So I'm so sorry to ask you some question. These are like kind of, very sensitive question. This is my job that I have to ask this question because this is going to help me in your management. So, I mean, literally, you are wasting 1 minute, one
your
precious
time.
minute for this sign posting. And then, Dr. Alina, what, the candidates say, okay, do you mind me asking you some private question as well if they are inquiring about sexual history or something? So I really would like to have your words on this, please.
Actually, the thing is that Dr. Zabe, to be honest, in our setup, we like very rarely use signposting, very rarely, because they know it's a part of communication and they are going to ask. Yeah, in some scenario, for example, previously I've seen a girl, a 16-year-old girl in a pediatric accident and emergency, and she presented with pain, right iliac fossa pain, and then at that time it's very difficult because I have to inquire in front of the mother about the sexual history. Then I signpost him, I'm sorry, please don't mind, I'm going to ask you question. Yeah, and yeah, it's personal, I know, but it's my job, or like it's very important that it's very important for me to know that information. So do you mind telling me, is she sexually active? And then she said no. Then I say, okay, I'm so sorry, but I have to repeat, I have to check the pregnancy test because this is a protocol. Okay, so in some scenarios you have to do, but in a regular, for example, I'm sitting in the gynae triage. So gynae triage, I have many patients with postcoital pain, many patients with the abdominal pain, many patients with the early pregnancy. So this is a routine question. Do you have any problem in doing sex? Do you have any history of sexually shared infection in the past? Something like that. Do you mind telling me how many sexual partners you have? So we actually not doing signposting here. Even not a consultant, when they inquire history in front of us in the ward round, they're not doing any signposting, nothing. So I don't know why they are wasting their time, and that I strongly not recommend. But sometimes you have to do, sometimes in some scenarios you have to do that.
But not in every question. Like, I mean, do you mind me asking, do you smoke? And then they will stop. Do you drink alcohol? Then they will stop. And then they will ask you, do you mind me asking any recreational drugs? So I personally believe that, I mean, there shouldn't
one
be.
thing Mr. Muhammad that I really like his, the way he explained, Mr. Muhammad. He said, like, just ask about, do you have any social habits? That's it. If there is social habit, then they will answer, yes, I used to smoke. Yes, I drink. Yes, I use alcohol and drugs. That. Otherwise, there is no need to go into the depth, because this is not a real patient, it's a role player, and it's a duty of role player to answer your question. So there's no need to waste time separately on do you smoke, do you drink, do you use no, nothing. Just ask about the social habit.
Exactly. I second you in this, and thank you so much. Thank you so much for giving your input
you know
in this.
everything. You're an examiner, so you know that.
No, seriously. No, because these days I am facing so many candidates, and like everybody is wasting a lot of time in this thing. So I really wanted to have your input because you are at NHS at the moment. So of course, you have pretty much, the insight. I mean, the close insight on everything. So thank you so much for your input. I appreciate it.
Yeah, just one more thing I want to add, because sometimes when the patient presents with heavy bleeding, and sometimes when we find some cyst, for example, some complex cyst or some 6-7 centimeter cyst on scan, and when we inquire about the cancers that run in the family, then sometimes you have to do signpost. Please don't mind, and we ask these questions from all of the patient. Is there any cancer that runs in your family? So otherwise they will feel very bad. Maybe there is some cancer, or maybe say there is some and then and there's something bad that has happened. Just to calm them, just to relax them, this is something which is very normal. So otherwise, I don't think so before sexual history, before smoking, alcoholism, because it's actually wastage of time. You have 10 minutes and they are very precious 10 minutes.
Yes.
And this signposting, you're not going to gain any marks, to be honest. You're not going to get
Exactly. Thank you so much. Okay,
thank
please
you so
carry
much.
on.
Thank you so much. You are here for us. Okay, so moving forward, and this is all about your dressing, this is all about your body language, your communication, the way you carry yourself, very important. You should look decent, you should look beautiful, and you should have your smile on your face unless it's not required. Okay, so arrival and greeting. So you don't get a second chance to make the first impression. So this is the first chance. So yeah, introduce yourself by your name, by your role, confirm the identity from the patient. It also comes under patient safety, and confirm the purpose of meeting. Okay, so you can say, okay, I believe you're here today because you have the problem with the bleeding. I believe you're here today because you just have a scan done today. You're here to discuss the result of your scan report, and I have a letter from your GP, and I believe you have some pain in your tummy, and or you can say, I believe that you have some problem with the vomiting, you have some problem with the nausea, whatsoever is mentioned on the notes outside the cubicle. Then you have to explain this before starting the conversation. It actually saves your time. So if nothing I have mentioned, then you can say, okay, how can I help you today? My name is Alina, I'm one of the senior doctor, and can I confirm your name and age, please? Okay, it's nice to meet you, Sarah. So how can I help you today? Okay, it's like that. Okay, so handshake important because of the COVID situation. We are not doing handshaking and these things, but probably from the May, maybe the restriction will be over. Then you can do even handshaking as well. Okay, so if you can see the picture like this, and this lady is actually breaking bad news. Okay, so the candidate is breaking bad news. So see how the expression, see the expression on her face, see her body language. Okay, so it's very important. So this is a safe distance between you and the patient. Okay, it should not be too much close. It should not be too far away that patient is not listening you. Okay, so I'm going to show you one video because one of the most important aspect of the communication is breaking bad news, which is a little bit tricky as well. So I have listened some of the recording from our candidates, and literally I was not expecting that sort of, that the way they were communicating, like Dr. Zay, absolutely right. It looks like a robot, like their robotic expressions and the way of talking. They don't know how to do that. Okay, so it's just a small video, and then we will discuss few things about the breaking bad news. And inshallah, in our module-wise session, we will do a couple of more tasks related to the breaking bad news, and then you will directly encounter your mentor, and then they will let you know and even perform in front of you that how to do that. Okay, and what will be your expression, what will be your body language, how to answer patient question, how to show empathy, and how to deal with their concerns, everything. Okay, so this is just a short video of 2 minutes.
Whether it's something you do every day, once in a blue moon, delivering bad news is never easy. Here are 5 scenarios, each depicting one of 5 steps in the process of giving bad news. Following this process will help you deliver the news, help you to look after the person who is going to get it, and look after yourself too. Step 1 is about preparing. Take a few minutes to gather your thoughts before you have to break the news. Breathe. Find a quiet, private space, somewhere you won't be interrupted. It's a good idea to have a colleague with you, someone who can be there as an extra support to you and to the person getting the news. Make sure you know all of the relevant facts, what happened and who was affected. Try to avoid using loose phrases like your brother, in case they have more than one brother. The second step is about person-to-person connection and human kindness. Take a bit of time. It's really important to make a personal connection here. Sit down with the person. Find out if they have any inkling or knowledge of what has happened. Then, step 3 is about actually breaking the news. Start by giving a warning shot to allow the person to prepare themselves. I'm sorry, but I've had a call from your brother John, and I have some bad news to give you. Avoid jargon. Break the news gently and slowly, using simple and clear language. For example, I'm sorry to have to tell you that your mother has been in an accident. Bad news can feel like a stomach punch. People who are shocked cannot take in a lot at a time. So break the news into chunks, making regular checks for understanding. If they are silent, remember this doesn't necessarily mean that they have absorbed or comprehended all that you've said to them. Check again and repeat anything that hasn't been understood. The fourth step is about dealing with the person's concerns. Give the person time to take the news in and to respond. Don't be tempted to fill the silences or to rush ahead with further details. Give them time to voice their concerns before you start giving them practical details. Wait. Wait. Check and listen. Acknowledge the shock. I'm sure you weren't expecting to get this news today. It must be a terrible shock for you. Wait. Let them respond. It can be useful to repeat the headline news one last time, as it's unlikely they will have grasped everything you've said. The fifth and final step is about follow-through. When they're ready, tell them what you have organized for them, what happens next, and what support is available. Claire here is going to help you to get home now. And here's a reminder about support and compassionate leave. If you have any questions at any stage, just call me. Just remember, you can never make bad news good, but the way you deliver it can have a huge impact. Finally, don't forget to look after yourself. This was probably quite difficult for you too. Make sure to take a few minutes to debrief with your colleague. These steps are just a few simple reminders to help you to deliver bad news on the hopefully rare occasions when you have to.
Okay, so this is a short video. Okay, so different mentors a different approach. So I have a different approach. Maybe Dr. Zay will have a different approach, but Dr. Muhammad will have a different approach. Dr. Pooja will have some different approach, but the steps are the same. Okay, so it's not like that. If you encounter a patient and, for example, there is a bad news of miscarriage, for example, there is a bad news of a cancer. So it's not like, okay, I'm going to give you a difficult news. I'm sorry you have a cancer. It's not like that. You have to follow some steps. Okay, so there are different models. One is these 5 steps. Prepare yourself. Okay, a quiet space with a colleague, even, or sometime with a sporting midwife. Okay, and make a connection, introduce yourself, and explain them that why you are here today. For example, hi, my name is, hello, good morning, my name is Dr. Alina. I'm one of the doctor here in the antenatal clinic today. So I just want to discuss something very important with you. Okay, so are you okay for me to call my sporting midwife? Or do you have anyone whom you like to call and ask them to come in because today I just want to discuss some very important aspects with you about your scan. Okay, so you can give a warning shots and today I have a very difficult news for you, and then stop, give them some time to react, and then you can say that I'm so sorry that the result is showing the baby is no more. The result is showing it's like it's a cancer. So you have to convey this news very clearly, very, very clearly, and in the form of small chunks, and then give them some time to react. Okay, show them empathy. I'm so sorry. I know this news is a big shock for you. I'm literally sorry that I'm the one who conveyed this news for you. And then you can press your hand on her hand and say, and we are not going to leave you alone in this difficult time, in this difficult situation. We will support you as much as we can. And once she say that she's ready to know what further plan you have for her, and then you can speak. You are not going to do this beforehand. Okay, and then you can say, okay, so are you okay for me to discuss about the next plan and how we are going to manage the situation, and or either you want to take some time and think and come back with your partner, and then we can discuss it again, something like that. Okay, and then give a practical support which is available, and the sport groups and the sporting midwife or mental health midwife, whatsoever is required. So actually there's 5 steps. So there is one more model here. It's a spikes model, very famous model. Okay, so whenever I break bad news, this model is always in my mind. So I follow the steps of these model most of the time. That is a spikes model: setting, perception, invitation, knowledge, empathy, and strategy. Okay, so setting is very important, that it should be a quiet setting, okay, away from the noisy place of the hospital. And sometimes you can encounter in your task that the patient, the candidate, that role play will be with the partner, or sometimes with the friend, or sometimes with mother. So you can ask from the role player that today I have a very today I just want to give a lot of information, and there's very important things that I need to discuss about your scan report, or about your pathology report, your blood report. And are you okay if I can discuss in front of your friend, or in front of your partner, or in front of your mother? Are you okay for that? If she will say yes, then you can discuss. Otherwise you're not going to discuss, because this is a breach in confidentiality. Okay, so it's against patient safety. If you you're not following the rules, which is basically very important, like you are breaking, for example, it's a news of azoospermia, for example, it's a news of a bilateral tubal blockage, so you cannot convey this news in front of their partner. Maybe they want to or for example, the news of HIV. So it's very important, if she is someone, then you have to take a permission, that is it okay for you that I can discuss in front of your partner? Okay, something like that. So setting is the first thing. Next is a perception. Okay, so I believe, Sarah, that you have a scan done today. Do you have any idea about your scan report, or do you have any idea about your blood report? Did your midwife discuss with you about the results, about your Down syndrome screening results? Okay, so maybe she already know about the results, then you don't have to follow all these steps. Okay, the next is an invitation, if she is alone, and then you can ask about Sarah, I just want to know, are you come here alone, or do you have someone with you? If you have someone with you, would you like to call and ask them to come? Okay, so today I have a difficult news for you, Sarah. Okay, so then you can give the warning shots. Okay, so I'm so sorry, Sarah, the results are not as we were expected. We were expecting to have a normal results, we were expecting to have a normal ultrasound report, but it's not like that, Sarah, I'm so sorry. So then she will say, what happened, doctor, can you please tell me? Then you say, Sarah, I'm sorry, the baby is no more, we have not found the baby heart, baby is died. Okay, and you can say it's a cancer, or the results show and that you are having HIV infection. Okay, so just you have to be very, very clear in conveying the breaking bad news, very clear, that they should understand. If they will not understand, then you can repeat and explain them again. The results show that your ovaries are failed. Okay, that is we call it as a premature ovarian failure. Okay, so the results show the baby is not a normal baby, the baby is having some major abnormality. Okay, so whatsoever the result shows, you have to be very, very clear, and then give them some time to react. If there's some tissue there, give them some tissue. If she's crying, give them some water, and then you can ask her to calm. I'm so sorry, sir, I'm so sorry you convey this news. I know it's a very difficult situation for you, this is a traumatic news, and I'm literally sorry that this happened with you. So as the thing explained in the video, that the breaking bad news is just like a big bomb, it's just like I can say, you can use some more words, like even if I would be at your place, I will hear some exactly the same like you, and then gives them some time to react. And if they have any question, then you have to answer, and then you can give them an opportunity. If you want, we can end the consultation here, and I'm going to arrange another appointment, so you can come with your partner, you can come with any of the friend, then we can rediscuss about the plan. Okay, and at the end, if she will say, no doctor, I'm okay, what happened next, what you are going to do next, then you can make a strategy. So it's basically, there's the steps of the breaking bad news. You cannot break the bad news just like a bomb. Okay, you have to follow the step, you have to use certain words, you have to show empathy on your face, your expression should be very empathetic, you have to lower down your tone, but that role player should listen what you are saying. Okay, you have to show them that you are feeling her pain. Okay, and you have to react what they are saying, you have to react. Okay, so breaking news, inshallah, we are going to practice in our life. Say multiple breaking news, bad news task we are going to cover, inshallah, in our session. Okay, so moving forward. Okay, So the next is the component of in the consultation. The first that we have discussed, the initiation, the session, how we are going to initiate the session, that the gather information, which is about the information gathering, domain 3. So the information gathering, it's always better to start with the open-ended question. And what are the open-ended questions are? You can say, tell me something more about your pain. Can you tell me something more about your bleeding? And how does it make you feel? Is it affect you socially, emotionally, psychologically, economically? You have to show some empathy. I'm so sorry this happened with you, Sarah. I will try my level best to help you in this situation. We have a certain options available, but I just want to know some more information from you because we are meeting for the first time. So can you please give me an example how this pain be like? Is it a dragging pain? Is it a menstrual pain? Is it a sharp pain? What type of pain is this? How it affects you? Can you describe that for me? How, why, when? So these all are the open-ended questions. So once you ask the open-ended question, then the role play will give you as much as maximum information. So it is always good not to interrupt in between. If you will interrupt in between, it will affect your communication. It's not a good sign. Okay. So in gather information, I put some journal template, obstetric history template or gynecological history template there. It will vary from case to case. It's not like you can apply this to every scenario. It's vary from case to case. And we will show you our template. And I have a different type of templates. Dr. Zaib has a different type of template. So every mentor has their own way of taking history and own way of the case presentation and their own way of communication with the colleague. Okay, so this is just a general template, and then we will do it inshallah case by case. Then we will show you our templates as well. Okay, so first is introduction. As I already explained you that there are two schools of thought. Number one is after when you say, hi, I'm Alina, I'm one of the senior doctor in the antenatal clinic today. Can I confirm your name and age, please? How would you like me to call you? Nice to meet you, Sarah. Okay. And another school of thought that we practice here in UK, and me, my colleagues, my consultant, everyone practice like this. We just confirm the patient name. First, whenever we see the name in the notes, then we say, Michelle Robert. Hi, this is Dr. Alina. I'm one of the doctor in the clinic today. Nice to meet you. Okay, so it all depends upon you. It depends upon your practice, whatsoever you want, and both are fine. Okay, so then the next step is to summarize the information available, and you can say, okay, so I have a letter from your midwife, I have a letter from your GP, and I believe that you are 20 weeks pregnant today. So congratulations. Okay, so then you can set an agenda, and I believe you're here today because you have the baby is not moving good, or you can say I believe you're here today because the waters are gone, and today you are here to discuss with me about the further plan. Okay, is there anything that you would like to add on, or any concerns that you want to discuss with me before we are going to start our consultation? Okay, so you can explore your concerns here when you set an agenda. Okay, so at the same time, you can say, okay, so I'm going to ask few questions from you because we are meeting for the first time. And then I will examine you in case of need. I will run some of the investigations, and then we will make a plan that is a shared management plan between you and me. And then I will write a letter to your GP if it's required. Okay, then you can start with an open-ended questions, and the same manner that can you tell me something more about since when the baby is not moving? Is it a first episode or a second episode? And then she will tell you about her history. Okay, and after that you can incorporate close-ended questions, and from the close-ended you can ask about, okay, how's your pregnancy being progressed so far? Any complication to date? What about your blood results, booking, prenatal serology, everything fine? So just in one quest, like in one statement, you can ask, okay, your booking results, your perinatal serology, everything was fine? Okay, perfect. Okay, can you tell me something about your past pregnancies? It was normal delivery, cesarean section, any complication, any problem at that time? If she will say no problem, that means no problem. There's no need to go into the depth of that pregnancies. Okay, so how they are doing now? Oh, wonderful. Okay, so do you have any medical problem? You're following your GP, any surgery on your tummy or your down below? Any past history that is significant and you want me to know? Are you allergic to anything? A broad-ended question. Do you have any social habits, and like smoking, drinking, anything? If she will say no, then no. If she will say yes, then you have to counsel her that, okay, so Sarah, smoking is not good for your health as well as for the baby. So will that be okay if I refer you to NHS Stop Smoking program? They will help you to quit down the smoking, or help you to cut down your cigarettes first, and then you can quit the smoking easily. Okay. So, okay. So what do you do for your living, Sarah? Whom you live with? Are you okay at home? Are you feel well supported at home? Okay. So depression questionnaire is not you have to ask every time. Is only if you think there is some hidden agenda, if you think that is a case of domestic violence, if it's a mental health task, and then you can ask the depression questionnaire. Otherwise, it's not relevant. Okay, so I believe that there's a 3D. The 1D is domestic violence, the other is a DVT, and the third is a drug. So these are very important 3Ds. But the depression questionnaire is more important if you inquire, if in case if you are suspecting, like it's important in the preconceptual counseling, is important the booking visit. It's important if you're suspecting some mental health disorder, or either you're suspecting like there's some hidden agenda, like domestic abuse, if there's some like, you know, rape cases, something like that, then you can ask. It's not in every case. For example, you're sitting in triage, obstetric triage is not required at all until you are suspecting domestic violence. If you're sitting in early pregnancy unit, is not required at all, to be honest. Okay, you have to deal with the main concern despite of wasting your time. Okay, any family history of concerns, and anything that you want to add on. Okay, and then you can summarize. Okay, if I'm correct, this is your second number of pregnancy, you have previous vaginal delivery, you are 34 weeks pregnant, and the baby is not moving well, you don't have any history of pain, bleeding, and there's no medical problem at all, you don't have any previous surgeries. That's it. Okay, so then you can say, do you want to add on anything more? Okay, that's fine. Okay, so Dr. Alina, how important it is to ask about patient occupation? Can we omit it? It doesn't seem to be important particular case. You can ask Falak, what do you do for your living? It's a journal template basically. It depends upon the setting. In my next slide, we will discuss how the things vary in the setting. For example, if you are sitting in obstetric triage, just like an accident and emergency department, so you don't have to inquire about occupation. But if you are in the antenatal clinic, especially the patient is first time encounter with you for booking visit, then you have to inquire. Sometimes they work in some certain factory where there is exposure of certain toxic substances like carbon monoxide, and sometimes it's a doctor working in anesthesia department, sometimes some of like staff member working in radiology. So you have to inquire about the work status. Okay. Okay, so this is about journal obstetric template. Okay, so it very depend upon the task, type of the task. Okay, it got it. Thank you. Okay, thank you, Falak. So the next is a journal gynae template. Okay, so obviously introduction, two types of introduction that I tell you. The one is that you can confirm the patient name and age, and second is that you can just inquire the patient that is it your name, and then you can introduce yourself. Summarize the information available, the same thing. Set the agenda. Okay, Sarah, I'm just going to ask you questions from you as we are meeting for the first time, and then I will examine you and will run some investigation. Then we will make a plan that is a shared management plan between me and you, and then I will write down to your GP if it's required. Okay, start with the open-ended question. Can you tell me something more about the pain? And then she will explain you everything. If it's a bleeding, can you tell me something more about the bleeding? And then you can incorporate close-ended question. Okay, so is it a first episode? Do you have any episode in the past? And what's the date of your last period? Is your periods regular or is it irregular? Is it just a heavy bleeding? Is it an irregular bleeding? How many children you have? Either they deliver vaginally or by the normal vaginal birth or by cesarean section. That's it. History of sexually shared infection. Okay, so do you mind telling me, do you have any history of a sexually shared infection in past? Any vaginal discharge, foul smelling vaginal discharge from your down below? Any problem while doing sex, like pain, bleeding, anything like that? Perfect. Okay, any medical problem you're following your GP? Any pain in your tummy, any surgery on your tummy or your down below? Any significant past history that you want me to know? Are you allergic to anything, especially latex? Are you allergic to latex? No. Do you have any social habits like smoking, drinking? What do you do for your living? You can skip this thing here in gynae if you want to. Whom you live with? Are you feel well supported at home? Are your smears up to date? And they are normal. When you have your last smears done? Okay, so any cancer that run in your family, very case to case. It's not required in every case. Okay, very case to case. anything that you want me to add on, and then you can summarize the history. Okay, so smear history, contraception history is important in gynae. Sometimes it's important in obstetric history as well. For example, if you have a patient with ectopic, you're suspecting ectopic pregnancy, then you have to ask about the contraception, because IUCDs and implanon and progesterone pills slightly increase risk of ectopic pregnancy. If you have a patient early pregnancy with bleeding, you have to inquire about the smear history. You have to inquire about the postcoital pain and postcoital bleeding. So sometimes you have to ask about the smear history in obstetric case. Otherwise, it's not required. Please, everyone, this is my advice. Please try to take a relevant history. Okay, I have seen many candidates who are wasting a lot of their times in just inquiring history, and they waste 6 or 7 minutes from the 10 minutes just in history, and then they will have just 3 minutes to complete the task. Okay, so for history is just 2 minutes. I believe you should not waste more than 2 minutes in history. Your history should be very quick. And to be honest, here in NHS we take a very quick history. Okay, do you have any surgery? Do you have any medical problem? Are you following your GP for anything? Are you allergic to any medication? Okay, do you have any cancers that run in your family? Okay, so do you have any social habits? It's like that. Okay, 5-6 questions and then history finished. Okay, so this is about the history template, and next is a physical examination. Examination is not required in every case, but in some cases very important if you think that is going to give us a relevant information. Okay, so the one thing that also comes under patient safety is in the presence of chaperone, which is important. Okay, and ensure her that I will stop if it hurts. Okay, gynecological examination is very intimate, so some ladies may feel embarrassment, so it's very important to explain the rationale behind. I'm going to, it's very important for me to do that examination. It's just like a smear test that have been done for you so far, and I'm going to apply some gel so it will not hurt. Okay, so I just want to see the neck of the womb because you are having bleeding. I want to rule out either the bleeding is coming from the womb and either the neck of the womb is open and closed, or either it's coming from the cervix, that is neck of your womb. Okay, so it's very important to explain rationale. So next part of the communication which is also applied knowledge, that is explanation and planning. So maximum 3 to 4 minutes. Deal with her concern. You have to convey the information in the form of chunks. Okay, chunks. See either she understand or she is having any questions. Deal with her concerns. Respect confidentiality. Appropriate signposting is if it's required. Provide dignity, respect, and then summarize. Okay, summarize what you have planned. Okay, for example, it's a case of VBAC. Okay, and you have discussed both options, either to trial of vaginal birth after cesarean section or elective cesarean section, and then you have given her both of the options. Then you can say that, what do you say? And she will say, no, I want to think. Then at the end you can summarize, okay, so we have discussed about the risk benefits and the complications of vaginal birth versus cesarean section. I'm going to give you some information leaflet. You can go home and have a look, and once you decide, and then we're going to fix another appointment and we will discuss and make a plan whatsoever is suitable for you. Okay, both options are equally best. It depends upon you, what do you want. Okay, if you have any question, you can ask from your midwife. Okay, so it's like that. At the end, summarize is very important. It's very important to properly close the conversation. It properly close that loop. Okay. Okay, so what to read to keep yourself up to date. So if you like the knowledge is not up to date, then you will not be able to properly clear and to pass this to me. So GTG is all Green Talk guideline, very important. You have to revise NICE guidelines, certain important talk articles, and RCOG e-learning strategy stations, a video very important, especially the strategy case scenario case series are too important. Certain books, part 3 books, information leaflet, that is pills. Sport groups, you should have an idea about the sport groups, what sports groups are available. They are clearly mentioned in the pills. Video practice skills course, prompt course for manual for emergencies. So this is all the syllabus for part 3 is. You have to cover everything. And definitely we're going to discuss many things in the live session, and we will practice more and more some exam related scenario to keep you people well prepared for exam. So applied knowledge, you should be able to make DD. For example, patient present with early pregnancy bleeding. You should make an DD like it could be a threatened miscarriage. It could be an implantation bleed. It could be a miscarriage. It could be a spontaneous miscarriage or incomplete miscarriage. It could be a bleeding from cervix. It could be an ectopic pregnancy. You should be able to make differential diagnosis. For example, the lady present with abdominal mass. It could be a mass, a fibroid. It could be an ovarian mass. If it's with pain, it could be an ovarian torsion. It could be an appendicitis. It could be anything. Okay. Don't stick to one thing. Okay. So you should be able to make differentials. Okay. Clinical technical skills, instrumental delivery, surgeries, you have you need to revise all these things. Okay, so these like the instrumental deliveries and these the technical skills sometimes comes with the teaching. So you should have an idea how to incorporate these skills in teaching. Non-technical skill, the soft skills that comes under the communication skills, strategy stations, videos, important workplace and workforce issues we will discuss in our teaching session. Interpretation of charts, forms, and images, very important. So like for example, how to interpret the growth chart, how to interpret the cystometrograms. So it's very important. And images, and some images you should be able to identify ectopic pregnancy, intrauterine pregnancy. So certain radiological images are very important. Knowledge gap. Okay, so if you read and revise the guideline, then the knowledge gap will be covered. Need to revise a theory in view of part 3. So now there is a little bit different from part 2 in terms of the part 3, and then you should read like how you're going to apply that. Okay, so the knowledge is the same, but you have to revise in view of part 3. From manual for emergency that we have already discussed, very important. Okay, so in terms of communication with staff and communication with colleagues, what other thing is that is very important? That is that Muse chart. Okay, so Muse chart is basically like in every obstetric patient, in every even in gynae patient, in obs patients a Muse chart. For the gynae patient is a Muse chart. So you should be able to interpret that. Okay, so we are going to show you in inshallah in our live sessions with certain tasks and help you to interpret these news chart. Okay, so if it's 0, then that's fine. If it's yellow, then the midwife or nurse will escalate to SHO. If it's red, then it should be informed to someone senior, that is the registrar or the consultant level. It's like that. Okay, so it's used in HTU, antenatal, and the postnatal wards. So it's a simplified version. Okay, so complete full set of Muse observation. If 1 yellow, repeat observation in 30 minutes. And if 2 yellow or 1 alert, call obstetrician and repeat observation in 30 minutes. If 2 yellow or more than or equal to 2 red alert, immediate review by obstetrician or repeat observation in 15 minutes. It's like that. So this is a protocol. So in NHS, everything is according to the protocol. So you have to follow the protocol, then there's least chances of litigation. So maternity dashboard, I have planned a few sessions, and inshallah in the first session, after this, the next session is on clinical governance, in which we are going to discuss the maternity dashboard, and I'm planning to show you the maternity dashboard, the recent dashboard of my hospital. And in my first session, I just want to make sure that want you people to prepare best for this. I want to help you people to prepare best for this dashboard in my first session. So in the next couple of sessions, we will again discuss little bit maternity dashboard, and I want you people to best prepare even in in my first session, so that in the next session, if you will have any difficulty, then you can ask the questions, and we will try to solve the query there and then. Okay, so the maternity dashboard is also a part of clinical governance. Okay, so it's a way of communication, very important way of the communication. So the concept of maternity dashboard basically comes from this car board dashboard. See the car board. This is a car dashboard. All information, how much the fluid is, the air in the tires, and the speed, everything is there on the dashboard. So maternity dashboard is like the same. Okay, so it's a virtual display used to monitor the performance of a maternity unit against a locally agreed standard. So every trust in NHS has their own local protocol. So it's basically that dashboards show how we are according to the standard, according we are up to mark of the standard, and according we're just going to breach the protocol, and according we have just like, or either it's a red that we have breached. So it's just like a traffic light system. Okay, either we are the happy face, see the green means that we met the standards, Amber means that we have not met the standard, but we have not entered into the red zone. Okay, so we are just about to breach the protocol. And red means that we breach the protocol and something bad has happened, something need to report the risk management, and we need to do some audit. We need to improve our practice. Okay. So mostly the goal is to monitor the performance so that we can do early intervention to ensure continuous improvement in care. Okay, so it's a traffic light system, and green means goal met, amber means goal not met, and red means upper threshold is breached. So immediate action is required. So how it works? Parameters are according to the trust benchmarking. For example, my trust has its own guidelines. So it's according to my trust guideline. It's not according to the NICE or RCOG guideline. It will be a little bit similar to them, but not actually. So divide these parameters into green, amber, and red and monitor on the monthly basis. So there is a virtual display in every labor board on monthly basis. Okay. And what parameters used showed about the clinical activity that is going, the number of spontaneous delivery, instrumental delivery, third degree tier, PPH, workforce, either we are up to the mark, either there are sickness leave, what is the outcome, and risk management issue. So it did show 4 parameters basically. Okay. So this is a picture of the board. I'm not going to do the board today. It's just a picture to show how this board looks like. Okay, in almost every trust, there will be a little bit difference like in the board, but the background and is the same. Okay, so this is the maternity dashboard of Oxford University Hospital NHS Trust. Okay, so it's mostly green and some part is red. So in our next session, which is a clinical governance session, then we are going to discuss the board in detail, how to do that, and how we can compare. For example, just an example, if you can see there, once you start doing the maternity dashboard, you have to say, okay, so my name is Alina. I'm one of the exam candidates here today. And this is a picture of a Oxford University maternity board. Okay, so and what parameters are? It's showing the activity, showing about the workforce, it's showing about the maternal morbidity, perinatal mortality morbidity, risk management issues, it's showing about the public health. Okay, so these are the parameters which is displayed on the board. So maternity dashboard is basically a tool in which we monitor the performance in our hospital, performance in our maternity unit, and compare with the standards, basically local standards, to identify the things, and so that we can do early intervention to prevent something bad to be happen in the future. So it's basically to improve the quality of care that we provide to the patient. Okay, so this is a journal introduction. Fine. You can apply in any of the tasks of maternity dashboard. Okay, so next, I always ask my student to do, we can do even horizontally and we can do even vertically. I prefer to do vertically. So you have to compare the things. So for example, this is April 19. Okay, so you are going down, down, down. You can see here, if this thing is red, okay, and this thing is amber color. Okay, and if you go down, these two things are also red color. So you have to like, if you can see, the SVD is amber color, C-section is red color, and the consultant R's is red color, and midwife birth ratio is also red color. Okay, so in April, then you have to like correlate with each other. It's all about correlation. The more good way you correlate, the more better you can do the maternity dashboard. If you can see, there's less SVDs, okay, in the month of April, and there are more cesarean sections. On the other hand, if you can see, there is less consultant hours cover, means there's a shortage of consultants, and there is less midwives. Okay, so in the month of April, the board is showing that there is more cesarean section rate and less SVD. So we want to know why there is more cesarean section rate. Okay, and on the other side, I can see there's a shortage of staff, which can be a biggest factor in increasing cesarean section rate, because labor was not properly monitored. So we need to look into the matter. We can do the audit, we can do the risk management to try to find out the cause why this happened, so that we can intervene early. Okay, so I just want to know either the ladies with previous one cesarean section were delivered, or either the cesarean section done. I want to know any of the breach present with in the second stage of labor, cesarean section done, or either the trial of breach was given or not. Okay. So I just want to know the look into the CTGs. Either the intervention was taken on the suspicious CTG, either fetal scalp sampling were used or not. Okay. So I just want to look into the indications of the cesarean section, and then we can make a protocol to, a local protocol, just try to reduce the rate of cesarean section. Okay. So this has happened in the month of April. But if I can see in the month of May, the SVDs become normal. So I really appreciate in May, June, July, August, September, it's all green. So they have done something to make it green, but it's again in October, it's again red. Means there is something which is missing. But I can see here on the same side, they again increase cesarean section. And on the other side, I can see there's a good consultant cover, but the midwife ratio also increased. So I can find out that the one of the biggest risk factor, the one of the factor we increase the cesarean section rate is a shortage of staff. That is what the board is showing. Okay, we need to do something. We need to, maybe there's a sickness leave, maybe it's because of the COVID situation, maybe it's because of the heavy workload. So we need to try to find out the cause. Okay, so always in maternity dashboard, you have to correlate the things with each other. Correlate. First talk about the red, and then correlate with the amber, and then appreciate the green. So this is the journal. Generally we do like that. Okay, so generally even we do with the maternity dashboard, we do on the regular basis here in our NHS. Okay, so we always do like that. Okay, so in my next session, clinical governance, then I'm going to do 1 or 2 maternity dashboard, and I expect you to do just like same. Any question here? Anything which is not yet clear? Anything? Asma, D, Palak, you want to ask anything? No questions so far. Very well explained. Okay, so in my next session of the clinical governance, we will do the maternity dashboard. It's very important, and it's one of the exam related tasks as well. So I want you people to be best prepared in our first session, and I want you people to be expert in a maternity dashboard, audit appraisal, and how to write a report, how to do incident reporting, all these things in the first session. Okay, and then we will try to incorporate these things again and again and again in the next session. Okay, so at the end, you all will be master in doing that. Okay, so this is the main agenda. Okay, so this is the other part, and I'm not going to explain bit like in detail this board, because I'm planning to discuss it in detail in my live session, like in my next session, which is on clinical governance. So, but the theme is the same. Talk about the red, compare with the amber, appreciate the green. Okay, so if we can see here, this is the red here and the red here in the month of May, in the month of June. What is the reason is the unassisted birth. Okay, so the rate is either increase or either decrease. Then you have to talk, if the rate is decreased, then you can say why the rate is decreased. Either the training is not properly done, either maybe because of COVID, the trainees have not attended the prompt live session, they have not attended the robust course of the training, which is very important, and maybe they don't have the skills of instrumental deliveries, maybe there's problem in the instrument, and maybe the patient factor, which is very important. And then you can compare with the 3rd degree or 4th degree tiers. Either the tiering is because of the instrumental faulty technique, and either is with the normal spontaneous vaginal delivery. What is the reason? So it's all about comparison. Okay, so with the comparison, you have to do vertically. You can do, you have to do, and it's very easy. Once you know how to do that, it's not a big problem, not at all. Okay, so this was about the maternity dashboard, and next with the communication with juniors. So this is a journal template of teaching. Okay, so first you have to introduce, and you are not going to say yourself doctor. You can say, hello, I'm Alina, one of the XT5, and you, and she will say, hi, I'm Lisa, I'm ST1. How are you, Lisa? How are you finding this department? You should have a smile on your face. Okay, so your body language, your body language, you have to show you are very calm, you are very welcoming. Okay, you have to show from your face that you are very happy that she is there with you. Okay, so Lisa, at any point, if you feel you need help, you need support, you have to tell us. Okay, so how you're finding this department, Lisa? Are you enjoying? You have any concerns? You can discuss with me anytime. I'm your senior. It's my duty to help you. It's my responsibility to help you. If she will say, actually, Rina, I'm finding it very difficult. I'm finding it difficult to cesarean section, or I'm finding it difficult. I've seen multiple instrumental want to do that, but I think I'm not confident. Then you can say, Lisa, everyone has passed through the same time that you are passing, and it will take some time. You are at the level of ST1. Once you will be ST2, 3, 4, 5, then you will be confident enough in dealing these situations. It's all a matter of time. It's a matter of training. It's a matter of practice. Okay, so don't worry at all. I'm here to help you. I'll let you know how to do that. Okay. Then you can explain agenda. Okay, Lisa, I'm just going to show you how to use this instrument. I will explain you some risk, benefits, and the complications. And I will ask some of the questions in between to have an idea about your knowledge and understanding. And then I will give you some sport material and some material to revise at home. And then you can ask me if you have any questions. And we will give the feedback to each other at the end as well. How does it sound, Lisa? That's fine. That's always fine. Okay. So explore, consent, set agenda. Then you can speak and stop, check her understanding, speak, stop, speak, stop is like that. Okay, and then you can summarize, give the feedback. Okay, Lisa, can you please give me the feedback, how it goes today? And then you can give Lisa, you're very confident, you are very keen to learn, and I'm so happy you are here. You are very enthusiastic, and you can give whatsoever you think that she did well. You are very keen to learn. And then you can give a recourse for the future learning. So it's a journal template of teaching, and you can apply it to any of the teaching. Okay, but few things will be different. For example, bullying is different. Okay, the template for the bullying is different. So we are going to cover in our next clinical governance session, or either in my teaching session. I'm going to take your teaching session. So probably I will cover in the teaching session about the bullying, the steps of the bullying, where you have to report and how to encounter and how to deal if someone is affecting for bullying. Okay. So sometimes little bit things different, like OSATs, few of the candidates find is very difficult. I know it's very difficult. When I was in Pakistan, I was finding very difficult to handle this OSAT task. I think it's very difficult. But now I'm working here. I know what OSATs are, how they should be signed off, what are the benefits of the OSAT, and how it's going to help in the training. So in the next session, teaching session especially, we are going to do a couple of OSATs, and I will give in the homework so that you people will be well prepared before the exam. Okay. So closed session, which is also a part of communication, briefly summarizing the consultation, written information, check understanding, inform GP. So it's the closure of the loop basically. A couple of materials is available to prepare for the exam. The one of the most important and recommended part 3 MRCOG book, that's the Lisa Joel, which is very important. All tasks very important. I strongly recommend you all to revise this book at least 3 times. Tasks for part 3 MRCOG, and there's another book which is very very much in use nowadays. That is, I think, Justin Conger. It's very important. I've seen some of the tasks. Is being written by one of our teacher, Mr. Justin. So I strongly recommend you to revise just Lisa Joel and the tasks for part 3 Oxford. A lot of tasks are there, all relevant, very up-to-date book. And Justin Clark, very important. And Tony Hogwin, if you think that you want to revise something extra, then you can also go and revise this thing. RCG learning, very important. So yeah, go to the RCG learning, especially the case discussion, because the answer of the case discussion is just according to the way that we answer in MHS. So I strongly recommend you, all of you, to go through e-learning. Okay, so now about our part 3 course. Okay, so what are the benefits? So the benefits of our part 3 course is we actually make you people well prepared before your exam, and we develop very effective communication skills. Okay, so we will enhance your presentation skill, the way you present, and every time you feel yourself when you present the case, next time you feel yourself, you're improving with the feedback. Okay, so better decision making, you will be able to make differential, you will be able to negotiate, you know your limitations, you know where to escalate, when to escalate, how to seek help. High level of self-confidence, and final practice before exam, and clinical presentation skills improve, and actually we accelerate your personal performance. So this is what our aim is. This is the benefit of this course. Okay, so the course features are the recordings will be available till exam. I've seen many many companies basically, and they only offer recordings till the end of the course. Okay, but our recordings are available till the end of the exam. This is the biggest feature of the course, and all templates is actually we are going to do the spoon feeding, to be honest. So all the templates for all modules are available. I have made the templates for maternity dashboard. I have my own templates for clinical governance, for audit appraisal, incident reporting, everything. We have our own templates, and that templates is being made by me and the RCG examiners. So I believe that templates are very, very helpful. Even if you could read the template, you will be able to make your own templates. We will encourage you and help you so you can make your own templates, incorporating some of the things from our templates. Okay. Okay, so exam-like templates for all modules. Separate study group for 24/7 study assistants and instructed NHS or RCG examiner. This is the biggest feature. Support will be provided to you till exam, and free course library, and we will tell you what is a passing criteria, what you can do to pass the exam. We will build the confidence in you. We will enhance your communication skill. Basically, to be honest, we have a very personal, me, Dr. Zaib, Mr. Hassan, we develop a very personal relationship with our students. Okay, so it's not just like that only in the study groups. Sometimes on the personal level, we help them and support them to improve their skills. It's like that. Tips to strengthen your weakness, and the very good summaries are available in the library, like talk, GTG, nice summaries. So for the part 3, just the summaries are required. There's no need to go into the depth. Individualized evaluation by RCG examiners, and audio written feedbacks, module-wise live session, and access to intensive study material. So there's a huge number of the features of our course. Okay, so what mentors are going to do? So my next session is a clinical governance. So what I'm planning to do is, from today, I'm going to give the homework related to the clinical governance. Okay, I will share some videos, some leaflets, and give the feedback on the homework. Maybe I will share my templates to revise before discussing in the live session, and then interactive weekly session. We will discuss the exam related tasks or some of the very important templates in our live session, and then revision. So it's a loop like that. Okay, so this is one of the screenshot of our schedule. Okay, so if you can see here, our course is started from today. And today is 12 February in the first exam introductory session, which is this session. And then next session is a clinical governance session that I'm going to take. Then antenatal care I'm going to take. Okay, so a few sessions from Mr. Zaib, Dr. Zaib, Mr. Hassan, and that's it. Okay, so the course is going to end on 8th of May. And it's how many number of sessions? 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18 sessions. 18 sessions are included in the regular course, and I believe that almost we are going to cover each and everything related to the RCG Part 3 curriculum. Okay, because it's not only this live session, a couple of things we are also going to cover in our group activities. Okay, so I strongly encourage all of you to please join our course, and I believe you will be a lot of benefit from this course, and you are not going to regret. Okay, so we're planning to share the topic tracker even in our in the live groups. This is what I'm going to share today, because my next session is a clinical governance. This is what I want my student to prepare, and I've also mentioned about the resources where they can revise. So audit, they can revise from RCG e-learning. They can ask the question if they have any. Maternity dashboard, RCG impact paper, and I will share my template. Risk management, I have my own template. I will share in the group, and also from the RCG e-learning. Audit appraisal, I have my template. I will share, and they can also revise from RCG e-learning. Sharing effective handover trust guidelines, and research development mentor template, and that's some SIPs from 2019. Okay, so we will give the tracker, so our student will have an idea that what they have to do, from where they have to cover, and they have to do the first revision now and second revision just before exam. So 2 revisions are basically required before the exam. Okay, so we are going to keep an eye on the progress of our student. So either they are progressing and either they are not progressing. So this is what they have to do in 1 week. In the next week, my next session is an antenatal care. So I have put the topic tracker here. So what topic need to be covered is a fetal condition, what fetal conditions cover from there, where they are supposed to cover for NHS leaflet, and I will share the leaflet in the groups. Okay, fetal infection, domestic violence, multiple pregnancy, teenager pregnancy, female genital mutilation, STA. So a huge list of topics, but they have to divide in such a manner, need to be covered in 1 week, not more than that. So at the end of the week, they will be well prepared from these topics, and then we will have a live session in which we are going to do the task, which are very important exam related tasks. Okay. So if any questions, then we will be happy to answer. So everything is there, from where to read, what to read, when to read, everything is there. So I believe it's just a sort of a spoon feeding. That spoon feeding was not there at the time of my exam. It was so difficult to pass the exam. But I believe now it's very, very easy. Very easy, because your mentors are from NHS, your mentors are RCG examiners. They know how to make a core, they know how to make a course curriculum and how to incorporate that curriculum, because we are also the medical educators. Okay, so our aim is to improve our student and make them well prepared before their exam, make them best to prepare before their exam. Okay, so I have shared one of the picture of my template just to have an idea, because I have a different like I have my own template, my own way to making template. Ms. Zabe, Dr. Zabe has their own way of making template. So every mentor has their own way. So my way of making template is I always divide into 4 things. Okay, so for example, this is a template I have taken from one of the tasks of the lady with 40 BMI, or she's 28 weeks. Okay, so she's here for antenatal checkup. So you have to make a further plan for her pregnancy. So I divide what you have to inquire in the history. So it's a very structured history, so you are not going to waste your time. And patient safety, communication, and applied knowledge. Okay, so everything is on one template and on one slide. So we have a templates for each and every topic related to OBS, gynae, clinical governance, incident reporting, everything. So we will give you this template and we encourage you to make your own template. Okay, own template. So for example, this lady, how you conceive, congratulations, is it planned pregnancy, any complication to date? Okay, do you tell me about your dietary habits? Okay, so any pregnancy in the past? You can ask about 3D if it's a booking visit, otherwise not required. Any social, do you have any social habit? Any medication you are taking? Are you allergic to any medication? Any family history of concern? I just want to examine you, check your pulse, blood pressure, and tummy examination in the presence of chaperone, if you don't mind. Then if she's 28 weeks, so what is required at 28 weeks? FBC, red cell antibodies, urine for protein, GTT, growth scan, and uterine artery Doppler. Okay, so it's so much relevant. See, it's so much easy. If you have these templates, it's so much easy to prepare yourself for the task. So then what comes under patient safety? If you are not going to cover patient safety, you are not going to pass the exam. Advice to continue 10 milligram of vitamin D, and need to be well mobilized and fully hydrated all time. You have to rule out heparin allergy, because it's very important, because of the risk factor. Maybe you have to put her on the heparin injections. That is a prophylaxis. Okay, place her on the low molecular weight heparin for the 10 days postnatally. Water birth is, if she will ask about water birth, is not a safe option. So this is basically related to that task. Okay, it's a simulated patient task. She will ask the question, then you have to answer. Okay, so then the communication, and then the applied knowledge, antenatal management, labor management, and you have to explain complications. We are going to save IV line, active management of 3rd stage of labor, postnatally, low molecular weight heparin for 10 days, stocking, early mobilization, hydration, avoid estrogen containing contraception, Implanon, and reduce weight before next pregnancy. Yes, Asia, we actually do this with red cell antibodies at 28 weeks. Yeah. Okay, so this is all about the templates, and my way of making templates, that I put all information related to task on even on one slide, just to save your time. Okay, so student feedback, we have a very good feedback from our student, and previously, mashallah, with a very good result, almost 80 to 90%. So this is the feedback. I'm not going to read it for you, and it's just a picture, so you can have a look that how much our students happy from us. And I really appreciate if you people will join us, and it will be a wonderful journey. Okay, so registrations are open for part 3 May exam, so you can contact all these numbers, and it's a 20% discount we're going to offer. And that's it. Thank you. So any questions so far, everyone? Any questions? Asia, do you have any question? Mithil, Salma, Shaista? Hello, any questions so far related to our course? You can drop the question in the chat box. Our team will be happy to assist.
Dr. Alina, any question about course or any question, I mean?
You can ask any question, Asia, if you have anything that you want to discuss.
Can you talk something about SARC?
The sexual health one, the SAR for the rape cases, is it?
Yeah. Yes.
Okay, so to be honest, Asia, here is that things that is related to any safeguarding concern. For example, if anything related to rape, if anything is related to the child abuse, sexual abuse, and that thing need to be dealt with a safeguarding team. Okay, so if you suspect that something like that happened, for example, I have encountered one case yesterday, and I was just about to discharge one patient with heavy menstrual bleeding. I just inquired from her that either she's okay to take a GnRH agonist, that is a Zoladex injection, and then we will plan endometrial ablation for that later on. Then she showed her concern that she's going to go back to Egypt. She's not feeling safe there. Then I further inquired, and she said, yeah, she had some sexual assault. Okay, so what was my job? I escalated to the charge nurse about that this patient has a sexual assault. I discussed with the patient. She's happy to inform police, and she's totally refused that I don't want to inform police. Okay, and still I called the safeguarding team that I have this patient. She has a history of sexual assault, and she's refusing to inform police. Okay. And at the same time, she said, okay, it's not your job now. You have escalated to us. Then we are going to come and talk with the patient, and we will discuss about the SARC and all these things. So we will take a sample if she is happy. And at any point in the life, if she will think that she want to complain and she want to go to police, she can go. It's like that. Okay, Asia?
So it means each hospital, they have their own safeguarding team.
Yes, my
and
hospital
there is named nurse or midwife is there.
Yes, the safeguarding team is basically their job. It's not my. I have done with a referral. I have your number. I will send you the referral that I have done for this patient. Okay, so the one thing that is very important, I was planning to discuss with my session. Thank you so much that you remind me. The safeguarding team told me that even if she is refusing to inform anyone, and even if she's not happy for us to be seen, and even if she's not happy to report to the SARC, still you have to report about the children to child social care. Okay, so the child social care is and you have to inquire a few things more about the name of the baby, like children, the age of the children, where they're living, if she's feeling safe or unsafe. She said that my children are with my mother in some I think in Scotland, and the children are safe, she told me. So but still, if they are safe, you have to report to the social care, child social care.
Okay, so the named midwife or nurse, she will contact with the SARC, and SARC is available 24 hours.
Exactly, she will contact with the SARC. You don't have to do it. The charge nurse, this is a responsibility of senior charge nurse. This is a responsibility of safeguarding team. And safeguarding team, the head of the safeguarding team, she called me later on, and she said if she's happy and if she consented, then you can inform police. But she refused to inform police.
Yeah.
Okay, and then the safeguarding team said it's okay, just give her hospital number and her name and address, everything. Then we will go at her home and discuss these things with her, that she's happy to involve SARC and either not.
So if she's happy, so then we will the safeguarding lead nurse will call the SARC anytime in the night, even in the night.
It's an expert who is going to take the sample, Asya. We are not going to take, because we are not expert. We don't know how to take that.
But I mean, the SARC is available 24 hours, even in the night patient comes or.
Exactly, and the safeguarding team is for 24 hours.
Okay, thank you.
Okay. So, any other question?
Yes, Dr. Alina, I'm Shaista. I want to ask that about focused history, if they have given in a task. So, even in focused history, we have to go for the that said templates, the all detailed history we have to take.
No, Shaista, actually, in the focus history is vary from case to case. Okay, it's vary from task to task. So, like for example, let's take an example of this task. Okay, so this is a patient simulated task. This lady is this lady basically for 38 years old with a BMI of 42 kg per meter square, 28 weeks, and she 28 weeks she presented for an antenatal care. Okay, so the focus history, like you have to avoid certain things. You understand what I mean? So what a focus if okay, so you are going to tell me, then I will let you know either it's a focal history or not. Okay, so the lady who is presenting with an antenatal visit at 28 weeks, what history are you going to take?
At 28 weeks, I will ask about her pregnancy, how it is going so far, any for what she came here and what are her concerns. And in obesity related to DVT in her family, and
Very
diabetes,
important is the patient
hypertension.
safety. Very important.
Yeah.
Yeah, there's
Yes,
no need to ask for
diabetes,
diabetes, hypertension. You can just about any family history of concern and or any illness runs in the family. Just try to ask open-ended questions because it's not a booking visit. 28-week visit means she already presented multiple times and you should have all her important relevant notes with you. Okay, so it's less likely that anything will be missed. And even if the father diabetic, mother diabetic, you are for her BMI, you are going to test her for the diabetes. So it doesn't matter. Okay. So while taking history, you just have to make few things clear in your mind. Is it going to affect your management or not? For example, there is no need to ask, I put in the template because a journal template, but to be honest, there is no need to ask, is it planned pregnancy or unplanned pregnancy? Whatever this pregnancy is, she is happy to continue the pregnancy, darling. So there is no need to ask that. Okay, how she conceived important, either IVF or not, and even if you will not ask, that's fine. But the most important thing here is, you have any problem up to date, any complication up to date. Okay, you can ask about, are you doing a little bit walk exercise? Fine. And even if you will not ask, it's not going to affect your marks. Okay. Okay, so you have any pregnancy in the past, any mode of delivery, any medical problem, any surgery, history of clotting in the deep veins of lungs and legs, and are you feeling well supported at home? How's everything at home? That's it. Okay, do you have any social habits, and are you taking any medication? Are you allergic to any medication? Okay, so that's it. There's no need to ask family history. So this is the targeted history. You don't have to add even a single word on this history. It should be completed in less than 2 minutes. Okay, because information gathering is not only history, it includes examination and lab investigations. Okay, so you can say that I'm just one of the nurses is going to check your pulse, blood pressure, and I'm going to okay, so if the patient is there with your scan report, and just check the date of the scan report. If it's today's date, then there is no need to do abdominal examination. What you want to look on the abdominal examination if the scan is just done today? The scan is shown as is a cephalic baby and these movements are fine and placenta is a normal position. And what you want to look on the abdominal examination? There's no need to look on abdominal examination if the scan is showing today's date. Okay. And then you can say, okay, so you're 28 weeks pregnant. So we're just going to check your full blood count to make sure you're not anemic. Certain antibodies, I'm going to check your urine for protein, just make sure you're not diabetic. And if scan is arranged, then there's no need. Mostly in high risk clinic, patient come with the scan. And otherwise you can say, I'm going to arrange a scan for you just to make sure that baby is growing well. Okay, so this is the well targeted history. So in every case, we're going to help you. Don't worry about that. Even if you will be a little bit irrelevant at any point, we'll let you know that here you are relevant and here you are irrelevant. It is all about practice.
Okay. Okay, thank you.
Palak, this is not a late booking, darling. This is a 28 visit regular visit. Okay, it's not late booking. Okay. Fine. Any questions so far? Anything? No questions? Okay,
Dr.
thank you
Alina,
so
one
much.
more.
Yeah,
One more question. In the like in the gynae board, it also included the gynae list patient, or it is a different patient?
It depends if they are admitted. It depends if they are admitted. So mostly the gynae list patient, they are the day surgery unit cases. They come straight away from home. Okay. So in the gynae list, sometimes it's a molar pregnancy who presented with bleeding and she's on the list. Sometimes it's a Bartholin, sometimes it's ectopic, sometimes with ovarian torsion, and sometimes, you know, with the heavy bleeding, she come and you planned hysteroscopy and biopsy for her. It's like that. Some patient who present in emergency and you have planned an emergency surgery for her. Okay. Otherwise, it would be a day surgery list patient.
Okay. Thank you. Thank you.
Okay, thank you so much everyone for joining. And when we will be able to practice scenario, ma'am, we have started the group activities. Okay, and we're posting the scenarios, just random scenario till now. And my next session is on clinical governance. So I'm going to share some dashboard and few things in the group, maybe related to audit. And I just want my students to practice and I will give the feedback. And in the live session, then I will show you my templates and then we will practice a bit more things. Okay. Okay, so thank you so much everyone for joining and do give us your feedback. It's just an introductory session. So I've just touched little things and inshallah in our next sessions and we are going to cover each and everything. Thank you so much. See you. Bye.